nitroglycerin. So now it is important to note, nitrates, historically have been known as kind of coronary dilators, but research shows that when you have an episode of angina, these drugs really don't produce a substantial effect on the coronary arteries that have already been hardened by calcification or have atherosclerosis. So in the setting of angina pectoris, the coronary arteries are already kind of maximally dilated. They're already as big as they're going to get to this chronic ischemia. And so the main effect of these drugs is actually going to produce a general vasodilation of the systemic veins and arteries, which is going to decrease your preload, decrease the afterload of the heart, which is going to reduce your cardiac workload and oxygen consumption. All right. Now, they're used in two different ways. So they may be given during an attack of angina to relieve the pain, which is usually your sublingual administration. They have a pretty fast onset of action. The duration is fairly short, and they may also be given prophylactically to prevent these attacks of angina. And that's usually going to be your patch or your paste, but are not usually used in the pre-hospital setting. For your mechanism of action, it's going to relax your vascular smooth muscle. So this effect is caused by the nitrate, which is chemically released from the drug, and it's going to be converted by your enzymes in the blood vessels into nitric oxide, and this is very potent but short-acting vasodilator. So it's going to relax that venous or that vascular smooth muscle. All right, and it's going to have a more effect on your veins than your arteries at the lower dose range of these drugs. So main effects produced by this vasodilation: decrease in venous return to the heart, which is going to decrease your preload, a decrease in blood pressure, which is your decrease in afterload. And so therefore your cardiac workload is reduced. And when you have a reduction in cardiac workload, less oxygen is required by the heart, relief of pain is accomplished. Now your indications, of course, chest pain, associated usually with acute coronary syndrome or acute myocardial infarction. You may also see it used for your acute pulmonary edema or CHF without presenting hypotension. Your contraindications: hypotension, that whole vasodilatory effect. We don't want to lower the blood pressure even more. If they have increased intracranial pressure, if they are in shock, if they have taken an erectile dysfunction medication within 24 hours, or if they're taking certain medications for pulmonary hypertension, you could have a disastrous drop in blood pressure. Quick way to know your erectile dysfunction medications: most people don't recognize them by their generic names, but they will end in afil. So sildenafil, and there's several different ones, but they all end at AFIL. Afil is their end. Now your dosage, usually pre-hospital setting, it's going to be 1 tablet, 0.4 milligrams sublingual, and you can repeat 3 to 5 minutes as needed. Usually no more than 3 tablets are going to be administered in the pre-hospital setting. However, MedControl may give you orders to give additional dosages. It also comes in a patch and an ointment. Now, your precautions. Patients who take this routinely may have a tolerance and require an increased dose to get the same effect. It can cause it can cause orthostatic hypotension, or they may have a postural syncope, where if they stand up too quickly or something, they can just hit the floor. So you want to keep your patient supine, seated whenever possible, and measure that blood pressure pretty routinely. Side effects: headache, weakness, dizziness, tachycardia. That's the compensatory mechanism for that small drop in blood pressure for that vasodilatory effect. It could cause dry mouth or skin rash, and occasionally nausea and vomiting. If they have recently ingested alcohol, the hypotensive effect is much more significant, and the orthostatic hypotension is also much more substantial if they take a beta blocker. So important to get a good history there and find out what other medications they may or may not be taking. Now, as far as your paste, 2% solution of nitroglycerin in this absorbent paste, it absorbs into systemic circulation, and it's going to have a longer duration of action. So for prophylaxis, it's going to be preferred over your nitroglycerin tablets, and sometimes is actually preferred in the hospital setting as well, because it's going to last longer. They don't have to keep giving them pills. They can do this ointment, essentially, measure it out and leave it, and it can be absorbed over the next little while. Your spray is an aerosolized form that it delivers the same amount of medication per tablet, so 0.4 milligrams per spray, which is very similar to per the tablets. And here you don't have to wait for it to dissolve, it's already there. Make sure that they don't inhale the medication though. And your infusion, all right? This is an IV infusion, and this is good when you need to have a continuous small dose of the medication given over a longer period of time. So your dosage for this would be 5 micrograms per minute IV and titrate. So you're going to increase by 5 micrograms a minute every 3 to 5 minutes up to 20 micrograms per minute until pain is relieved or the blood pressure is not decreasing any. So if you're doing this, you really want to use a pump to make sure that you are accurate in your prescribing or your administration. Now with the nitro, a little bit of patient education goes a long way as well, and for us, you know, a lot of these angina attacks are unpredictable, so usually the patients are going to carry the medication with them. But nitroglycerin, very volatile. The tablets will lose potency very quickly if they're exposed to air or light, so they need to make sure that they're carried in a light-resistant, airtight container. Also, typically, the recommendation is not to use any medication more than 6 months old, since you may have a pretty substantial loss of potency after that 6-month mark.